Good morning and good afternoon and assalamu alaikum to everyone. Welcome to the session 1 of day 2 of Pakistan Endocrine Society annual conference. My name is Dr. Umar Yusuf Raja. I'm a consultant endocrinologist at Shifa International Hospital, and I was responsible along with my colleague Dr. Fawaz Randawa, who is a consultant endocrinologist at King Edward Medical University, for arranging this session. We will begin by reciting few verses from Holy Quran. Bismillahirrahmanirrahim. Wal asr, innal insana lafi husr, illa allazina aminu wa amilu salihati wa tawasaw bil haqqi wa tawasaw bil sabr. Now the English translation. By time, indeed mankind is in loss, except for those who have believed and done righteous deeds and advise each other to truth and advise each other to patience. So today we have got two eminent speakers for our first session. The theme of our session is New Perspective in Diabetes Management from Daily to Weekly Regime. And I would now like to introduce Dr. Tejhmal Rehman, who is my colleague at Shifa International Hospital. Dr. Tejhmal have done his CCT from Kent and Sussex Deanley. He's MRCP in internal medicine as well as in diabetes and endocrinology. And he will be moderating the first half of the session. So over to you, Tejhmal.
Thank you very much indeed, Dr. Omar. Welcome, everyone. It's a great honor and privilege for me to be introducing and moderating this session. First of all, I would like to introduce Professor A.H. Aamir, who is our expert panelist. Professor A.H. Aamir is currently professor and head of department at Hayatabad Medical Complex in Peshawar, Pakistan. He's a past president of Pakistan Endocrine Society as well as AACE Pakistan chapter. He has various publications in national and international journals. His research work includes prevalence of diabetes in Pakistani population, as well as Safe Park study. And indeed, it's a great privilege and honor for me to introduce Professor David Russell Jones to our colleagues who are attending this meeting today. For those who are connected to the research field of diabetes, Professor Russell Jones need no introduction, for he is a renowned and distinguished researcher in the field of diabetic medicine. He graduated from Guy's and St. Thomas Hospital Medical School, London in 1985. He was a senior lecturer at Guy's and St. Thomas and a consultant physician. In 1998, he was appointed Professor of Diabetes and Endocrinology at University of Surrey and consultant physician at Royal Surrey County Hospital. His department has attracted large research grants and was highly rated in the university assessment exercise. His unit is housed in a unique ambulatory care and research center, which was designed by Sir Nick Grimshaw. His research interests include the use of stable isotopes to understand peptide hormone physiology. The Wolfson Foundation funded his mass spectrometry unit. He's also been principal investigator on a number of international clinical trials, including Levermade registration trial, duration 4, lead 5, take control, onset 1, among others. He has published widely on insulin, GLP-1 receptor agonists, IGF-1, and growth hormone. He's been invited speaker at many international meetings, including Diabetes UK, EASD, ADA, and GRS. He's also head of UK Civil Aviation Authority program to allow commercial pilots to fly on insulin. During the coronavirus pandemic, he was asked to set up a COVID-19 ward and has published on the disease. Professor Russell Jones, in his spare time, has an active interest in racing sailing boats and has previously represented Great Britain. Professor Russell Jones.
Thank you very much for the invitation to give this talk, and good afternoon, everybody. What I'm going to do today is talk about the sort of the newer areas of active research, and particularly look at the ultra short-acting analogues and also the new weekly once a week insulin that is just beginning to enter clinical trials. These are my disclosures. Now, the first question to ask is, why do we need an insulin analog? And if we look at the insulin profile of a normal person, which is shown on this slide, this shows the profile of human act rapid. And as you can see, its profile is nowhere near like the normal.
I'm so sorry, Professor, just to interrupt, but it looks like the screen is not being shared.
Okay.
You can't see the slides.
You'd like me to do?
Waqas, could you kindly confirm if the slides are being shared?
Is that better?
Yes, yes. Thank you. That's better. I think we can go into presentation mode now.
Okay.
Thank you.
All right. Sorry about that. Okay, we'll start again. So this shows the insulin profile of a normal person, and I hope everyone can see that. Good.
Yes.
This shows the profile of Act Rapid administered under the skin. And as you can see that its profile is nowhere near the normal human profile. This shows NPH under the skin and by subcut, and it shows that the profile is also nothing like the human profile. So the first thing is to say is that why we need analogs is because the profiles we need to improve. And then there is another fundamental point, which I'll illustrate here. This shows normal insulin physiology with insulin being released from the pancreas to the liver, and then that bit that goes through the liver then enters the systemic circulation. So the liver sees 4 to 5 times the amount of insulin that the peripheral circulation and the rest of the body sees. If you have diabetes and you don't have any insulin coming in the portal vein to the liver, we give insulin subcutaneously, and therefore the peripheral tissues are experiencing much more insulin, and the liver is seeing much less insulin. So we're delivering the insulin into the wrong space, and it has the wrong profile. And this is what has driven insulin analog design over the last 30 to 40 years. If we look at the current areas for development, ultra-fast analogs are a number of companies are trying to produce these. And this is to try and promote a more physiological postprandial insulin replacement, but also pumps and closed-loop systems, which represent the future for treatment of type 1 diabetes, definitely, will very much rely on technology to improve and make insulin act quicker so that the algorithms can cope better. The second area of active research is looking at very long-acting basal analogs, and there is once-weekly preparations, and the number of companies are trying to produce these. And then the last one, which is more speculative, is actually producing a smart insulin that is glucose responsive, and there is the first phase 1 studies are beginning to work to examine different strategies and possible candidate molecules. So let's split this in two. So the first thing we're going to talk about are the ultra-fast analogs. So why do we need these? Well, we need these to help with postprandial glucose metabolism. Now, all of the different societies have always had very different rules and targets for postprandial glucose levels measured at different times under different ways. And they're beginning to come together now, which is good, but there is still some discrepancy. Why do we need to improve postprandial glucose control? Well, as your HbA1c improves on the left-hand panel, this shows a number of people. This shows a contribution in yellow of postprandial glucose and gray, the fasting plasma glucose, to the HbA1c. And you can see that if your HbA1c is high, The fasting glucose contributes more, and therefore you need to target that in terms of trying to bring down the HbA1c. If, however, you end up at a lower HbA1c at a approaching target rate range, you find the contribution to the postprandial in yellow, you can see at HbA1c of less than 7.3, it's 70%. And therefore it assumes more importance, and therefore one should concentrate on that. On the right-hand panel, we just show the physiology of the day, and you can see that quite a lot of a 24-hour period, you are either in a postprandial state in light green, or in a post-absorptive state, and showing that this part of the day is very important. If we look at an insulin profile, which is on the left of a normal person who's eating 3 meals a day with clock time, you can see the profiles. Now, on the right-hand panel, the insulin secretion has been deconvoluted, and you can see that most of the insulin secretion occurs within 60 minutes of a meal in terms of the postprandial response. And overall, right at the bottom, it says here that basal secretion represents 50% and postprandial secretion represents the other 50%. So 50% of the time, your insulin the postprandial insulin plays an important physiological role. So these are the aims. The other thing is that I'm sure you've experienced the same, and that is when you put on flash glucose monitoring or CGMS, the first thing you find, and the first thing the patients find, is that the people are experiencing large postprandial peaks in blood glucose that they were unaware of. So a lot of people put on the monitors and then come back to us and say, whoa, my blood sugars are extremely high postprandially, and hence people are concentrating more on trying to get these down. And incidentally, when you put on the monitors, and here we have a profile of someone with monitor, we're also finding people are having hypoglycemic episodes at night that they were unaware of, and hence the need to get the basal insulin right. But we're going to come back to that a bit later on. So in terms of trying to work out how can you make an insulin more rapid in onset, well, you can do physical things. You can use a sprinkler needle. You can try pulmonary administration, but we sort of feel uncomfortable with that. Or you can try intraperitoneal insulin via a depot and some form of pump. So there are physical things. You can actually muck around with the formulation, which is a lot of people are doing. You can add things to the insulin to try and promote insulin absorption. And also you can use hyaluronidase as a coadjuvant, which breaks down the collagen and allows it to be absorbed more quickly. So look, we're just talking through that last one first. Here is a slide of a study in which people are given Lispro, Humalog, in the presence of hyaluronidase, which is the green line, and without in the dotted line. And on the left-hand side, we've got the pharmacokinetic profile, and on the right-hand side, the blood glucose following a meal challenge. And what you can see is that the peak is quicker and higher with the hyaluronidase. So this is, it does work, but we sort of feel uncomfortable giving the hyaluronidase. So then we come on to the formulations. Well, we've got BioChaperone Lispro, which is under development. We've got the Eli Lilly Humalog with a prostaglandin to improve local vasodilator. And then you've got FiAsp, which uses niacinamide and arginine as the means to try and get it in quicker. So this shows the pharmacokinetic profile of FiAsp, of ordinary NovaRapid insulin aspart, and this shows it in the formulation with FiAsp. And as you can see, that the onset of appearance is at 4 minutes as opposed to 9 minutes. That during the first 30 minutes, there's almost double the insulin exposure compared to ordinary insulin aspart. And if you look at the same profile that now extended out for 5 hours, you can see the insulin comes on more rapidly and leaves more rapidly. So it's roughly 12 minutes less time at 2 hours compared to the conventional insulin. And if we look at, that's the profile of the insulin. Now, if we look at actual dynamics, and that means the insulin action, this shows the glucose infusion rate following an injection of ordinary NovaRapid, and this shows following FiAsp. And you can see that it comes on more rapidly, and that during the first 30 minutes, there is significantly more glucose required to overcome it. So it comes on and acts more quickly, as well as its profile appearing in the blood. And if we look at the late effects in terms of the glucose infusion rate over a longer period of time, extended out the graph, you can see that roughly 20 minutes, 15 minutes earlier, it comes down. And that also helps to prevent the late hypo. So in summary, we know that FiAsp is twice as fast coming on. It's twofold higher insulin exposure within the first 30 minutes and 74% greater insulin action during the first 30 minutes. So it looks as though it's doing something. Now, the question is this of any clinical relevance? Which I'll come on to. Now, in terms of other options, we've got Biosafra and LifePro, and this is just beginning to enter clinical trials, but this shows its profile in green versus ordinary LifePro, and once again, it's quicker onset, quicker going away, and its profile is very similar to FiAsp. So that's one of the other alternatives. And then this is the Eli Lilly with the prostaglandin, and you can see also it comes on more rapidly in red and goes away more rapidly as well. So there are more than one player in this area, which is always good for the patients and for us as doctors. So what about clinical data? So Onset 1, it was the first big study that took place looking at FiAsp. This study was an interesting study in that there was a double-blind component. People took either fast aspart or insulin aspart before meal. These are type 1s who were controlled on detamir, and that was done double-blind. And then there was a third arm that actually used the faster insulin, but took it 20 minutes after a meal, which is not recommended, but a lot of people do this, particularly for children. It was followed up for 6 months. The key endpoints were HbA1c, and also there was a meal test as well that I will show you some of the results. So let's have a look at the results. So this was a change in HbA1c with ordinary insulin aspart during the 6 months of the study. This shows those who were randomized to FiAsp, and there was a significantly lower reduction in HbA1c in those randomized to FiAsp. But what I think was most striking was the group who were randomized to taking the insulin 20 minutes after a meal had an HbA1c that was no difference from taking conventional NovaRapid for the meal. So I think that really brought home its physiological possibilities. If we looked at the meal test, this is ordinary insulin aspart, and this in black shows the FiAsp, and you can see the postprandial excursion was lower, both at 60 minutes and 120 minutes, as you would expect from an insulin that comes on more rapidly. So what do we know? It's twice as fast as appearance in the blood, 2-fold higher insulin exposure, 50% greater insulin action, lower HbA1c compared to NovaRapid in the clinical trial, and that the post-meal dosing was non-inferior to the pre-meal of ordinary NovaRapid, and the glucose excursion was lower in the meal test. So that's clinical data. Now, one of the first areas that everyone was really interested in is, could this make a huge difference in pumps? Well, this shows on the left-hand side the profile in a pump study looking at its appearance. And as you can see, that it seems to be more impressive compared to the right-hand panel, which is subcutaneous injection, is that it seems to be have a greater difference, i.e. comes on more rapidly, goes away more rapidly, and therefore this might be ideal for a pump. And this prompted a pump study called Onset 5. In fact, we took part in this study, and it had a slightly odd protocol, and it was quite constrictive, and I think that's one of the problems with the study. But the two arms were compared. So what did the results show? Well, the HbA1c was no different in either arm. If we looked at the profiles which are on the left, you can see that at breakfast and lunch, the mealtime excursion was definitely lower, but at dinner time and overnight, something unusual was happening, and there was no difference. And I think this is, so this, I think it was the constraints of the protocol probably that inhibited this trial. But it wasn't quite as stunning as we were expecting, although it looks like physiologically, when we get it right in pumps, this will be the insulin of choice. And also, interestingly, a lot of the closed loop systems are using FiAsp because they think that it's a better way of controlling the algorithms. So in conclusions for the fast-acting insulins, postprandial glucose excursions were increasingly recognized with the glucose monitoring techniques, and we're finding these big mealtime excursions. Postprandial glucose excursions are difficult to treat with conventional insulin analogs. The ultrafast insulin analog allows a more physiological insulin replacement, and they're more effective at managing postprandial glucose excursions and represent an incremental, a small but incremental improvement in insulin replacement. I'd now like to move on to the long-acting analogs. And just to say that we've been through various generations of trying to make a flat insulin that has a long duration of action. Well, this molecule here is called icodec, and it's human insulin. It's got 3 amino acid substitutions, which were required to make the molecule more stable. It's got a spacer, and then it's got a C20 free fatty acid put on the side, which means it binds to albumin. And the how tightly it binds to albumin affects its duration of action and half-life. On this next slide, we have the after a single dose, the elimination, which is how you work out half-lives. And what you can see, this is in an animal model, and this shows the effect of adding different carbon chain length free fatty acids. And you see C14 is levomir in the green. And if you go up to C20, which icodec is, you can see its half-life is incredibly long, and it has an extremely long duration of action. So this is an animal model. This shows data from human subjects at 3 different doses. And effectively, this has a half-life of 196 hours, which means this can be a once-weekly insulin injection. So there's been great debate as to whether it would be safe, whether we should do trials. And the first trial has just been published in the New England Journal with Julio Rosenstock as lead author. And this shows the trial design. It was weekly icodec. These are insulin-naive type 2 patients, and it was compared to daily glargine. It was a double-blind, double-dummy design. So everyone was giving both glargine and or placebo, and giving icodec or placebo during the study, and didn't know which way they were randomized. There was a weekly titration regime. So this shows the demographic details of these people. Their HbA1c was around 8%, and their duration of diabetes was around 10 years. And these were classical insulin-naive type 2 patients. This shows the change in hemoglobin A1 during the trial. And as you can see, that the icodec was as good as the glargine, and the A1C achieved actually was slightly lower. If you looked at the percentage of people who achieved target, numerically slightly more of the icodec than the once daily glargine. And this shows the glucose profiles. In the straight line is the before, and the dotted line is after the intervention. Blue is icodec, gray is glargine. And you can see both when you introduce either of the insulins to insulin-naive patients, the glucose levels falls, but the glucose level fell further with icodec than it did with glargine. But importantly, it was no worse, and actually was better. This shows the insulin dose in terms of units, and slightly less icodec was needed than our insulin glargine in terms of the weekly dose. And then we move on to hypoglycemia, which is the thing that would concern most people. Now, and in many clinical trials, they define the hypoglycemia according to different levels. Level 1 is less than 3.9. Level 2 is less than 3, or which is clinically significant, and severe is severe. This shows the level of hypoglycemia during the study, and there was more level 1 hypoglycemia in the icodec group than the glargine group, but there was no difference in the level 2 or level 3, which was significant. So it appears to be associated with slightly minor hypoglycemia, but not major, and this is very encouraging. So in conclusion, that once weekly icodec gave similar glucose lowering to once daily glargine. The rates of severe level 3 or clinically significant hypoglycemia were low in both groups and were no different, and there were no other safety issues. So in summary of this talk, there have been major advances in insulin analog design over the years, and this has allowed a more physiological insulin replacement, because insulin was not designed to be given by a subcutaneous route. And this is why we do need insulin analogs, and we are making more physiological insulin replacement. And we're on the threshold of a big shift in terms of both the short-acting and the long-acting. And I think this will lead to very, very significant clinical advantages. And I'd like to thank you very much for your attention.
Thank you very much, Professor Russell Jones. Right, it was a very precise and illuminating talk, and I think listening to it was a pure delight. Before, I've got a question of my own, but before that, I would like to invite Professor H. Amir to share his comments with us.
Thank you, Tejhmal. Thank you, Professor Jones, for a very illuminating talk. It was wonderful to have you. And I think with the days to come, I think what is coming is that we just realize now that the necessity of using different types of insulin differ from patient to patient. And it is very obvious that it will carry on coming. And one of the biggest examples that we have was people with autonomic neuropathy or gastropathy. And with the CGM, we suddenly realized that their peak is much later, in fact, than the ordinary the people without any other gastropathy. And that's where the need of the older insulin probably would be a better choice. But very rightly so, I think our demand for insulin will keep on changing because no two patients are the same. And hence, I think the requirement of different types of insulin will make it better for the outcomes, what you have mentioned. I'm very interested with icodec insulin, which is very interesting. And I think in the days to come, this will be a relief for some of our patients because insulin phobia is all around the world the same. It doesn't matter where you're living. So thank you very much.
Well, thank you for that comment. I totally agree that we all have people who are brilliantly and lousily controlled on every different type of insulin regime. And you've got to find one that suits the individual patient. You know, what the analogues, the advances allow is potentially a more physiological replacement in a greater number of people. But I totally agree that it absolutely needs to be tailored to the individual.
Okay, brilliant. Dr. Omar, I think you do have a question for a professor.
Yeah, excellent talk, Professor Jones. Can I ask you a question, Prophet, regarding weekly insulin? Now, when degludec came, our biggest fear was about what if someone overdosed with degludec? Because that means that he's going to spend his time in hospital for maybe 3, 4, 5 days, even more. And with weekly insulin, given that the half-life is so great, that means potential problem with an admission that lasted maybe even half a month. So how do you think we can navigate that sort of basic problem?
Well, I think, interestingly, on a lot of the advisory boards, you know, a lot of eminent physicians were saying you can't do a trial, it's too dangerous. But basically, what we're trying to do with the background insulin is just sort of, you know, is very much to address the liver and hepatic glucose output, and that is easily overcome by counter-regulatory hormones. So I think that it won't be a problem, but basically if someone does take a big overdose, I'm afraid you will be hanging around for longer and there's no escape from that. So I do think there is an answer.
Thank you. There are a few questions in the chat box, but I just had one question of my own. Professor, the first part of the talk where you illustrated the normal insulin physiology, I think it was a helpful reminder to all of us that even though there has been exciting progress and development of various insulin analogs with improving pharmacodynamic profile, ease of delivery, but exogenous insulin via subcutaneous route is inherently flawed when compared to natural endogenous insulin physiology because the liver is getting less exposure compared to subcutaneous tissues. Could you share some thoughts on any new developments of what they call hepatopreferential or hepatoselective insulins and whether it is still a promising area to watch out for in the future?
Well, I must thank you for the question. Due to the anatomy of the liver, you can make larger insulins are more likely to affect the liver. So in fact, levemir is slightly hepatoselective and is more hepatoselective, is more like normal than conventional insulin under the skin. Interestingly, degludec and icodec are bound so tightly to albumin that they probably aren't hepatoselective. And you may know that Eli Lilly produced a hepatoselective insulin with a PEG polyethylene glycol chain, which made it very large indeed. And there were some problems with liver toxicity. And what we don't know is whether that was the hepatoselectivity or whether it was the PEG are causing the problems. But we are ideally would like to make an insulin that has the same balance 4:1, because that's what happens in normal physiology. So there is some hope that will happen as well.
Thank you. I think the next question I would like to have Prof Aamir to have his comments on that. Can we use basal bolus regimen in type 2 diabetes who are having poor glycemic control with combination of oral hypoglycemics and insulin?
Thank you very much. Yes, I think, as I said earlier, I think every patient is individual, and there are cases, and we see day in and day out, that patients with type 2 diabetes actually ultimately burnt out. And once they're burnt out completely, they would need a more aggressive insulin regime. Of course, there is an element of insulin resistance which was always there in type 2 diabetes, and metformin may have to be kept on board. But yes, once they are burnt out, it is quite possible that they might require a complete usual type 1 basal bolus regime for their management. And the aim is again to reduce the excursions which they will have, of course, not at the cost of a hypo, but that is one safety net we need to keep in mind.
Thank you very much.
Yeah.
Yes, Prof. If you do have any comments on that.
Well, no, I just agree. Yeah, no, I think that's, once you've lost your insulin reserve, you will need full replacement. Absolutely.
Okay, I think I can only take 1 or 2 questions. So there's one quick question, Professor Russell Jones, if you would like to comment on that. I think somebody is trying to ask if using insulin analogs in chronic liver disease patients is better compared to recombinant human insulins in terms of hypoglycemia risk.
Well, in terms of hypo, I think that all the studies show that when you use analogs, you reduce the risk of hypoglycemia. So, and insulin and people with liver failure will be just the same. There'll be no real studies looking at efficacy in liver failure, but there've been a lot of studies looking at safety in liver failure with particularly these albumin binding analogs, and albumin is, even when it's low, is such excess, it makes no difference at all. The analogs are safe to use in liver failure patients.
Thank you very much. I think we can take 1 or 2 questions. I will ask Dr. Omar to have a question that he would like to ask, please.
Yeah, I mean, Prof, this is not related typically to this session, but I would ask, we know the holy grail is going to be oral insulin. Well, I mean, are you optimistic? Maybe next 5-10 years time we might be having it, or is still too far away?
Right. Well, I think one of the companies did have an oral insulin that they thought was probably going to work, but you need an awful lot of it to get through the stomach and gets degraded, and if you work it out economically, it's just not worth doing. Because it costs too much to make compared to conventional insulin. So I think that someone will do it at some stage, but there are inherent problems. But by giving oral insulin, you're delivering it to the portal system, which has a huge advantage if you can do it. The people who've tried to date, there's been a great sort of variability from one day to the next, which makes life more difficult. But there is this other economic issue which will prevent people exploring it, I'm afraid.
Thank you. Professor H. Aamir, you have a question to make.
Yeah, on the same note of Professor Jones, what Omar just asked, is there any chance of buccal insulin? There's a lot of lymphatics around, and the absorption should be pretty quick. And we used to give people with thyroid replacement or celiac sometimes a buccal thyroxine. Is there any chance of that?
I'm not aware of any research on buccal insulin. Oral insulin people have tried, inhaled insulin, but not buccal. That sounds really interesting. Here you go, patent it.
There we go.
Okay, I think it's time to wrap up. I mean, just the last comment that I was thinking when I was listening about FiAsp was that we do have pediatric patients with type 1 diabetes. And I do observe, and it is distressingly, it's very distressing for the parents that after they give a mealtime rapid-acting insulin to their child, they have tantrums for whatever reason and simply refuse to eat their meal. I think FiAsp gives us that assurance and advantage of using insulin post-meal, and also an added flexibility in adjusting dose according to the food that's eaten, and thus avoiding hypoglycemia. I think it's a very attractive option for pediatric population. If you have any comments on that, Professor Russell Jones.
Well, it's not something that we would recommend, but basically it is absolutely this insulin. If you're going to do that, this insulin is better, and it shows that you can manage as well as. So yes, and pragmatically, particularly with kids, sometimes you just have to do it.
Brilliant. Thank you very much. I think it's time to proceed to the next session. Thank you very much once again, Professor Russell Jones, for joining us.
Thank you very much for the invitation.
Thank you. I will now hand over to Dr. Fawad for the next session.
Thank you, Tejhmal, for an excellent talk and excellent coordination. Not to wait further, I would like to introduce my second moderator of the second part of the first talk on today's first session, and that is Dr. Sarwar Malik. He is currently working as an assistant professor and head of department at Ayub Medical College, Ahmedabad, and he is supervisor, CPSP, and one of the eminent clinicians practicing in Islamabad as well. So over to Dr. Sarwar Malik.
Thank you, Dr. Fawad, for your kind introduction as well as your invitation. In this session, our chair is Dr. Ibrar Ahmed. Dr. Ibrar Ahmed is a consultant endocrinologist working at Lady Reading Hospital, Peshawar. He is president-elect. He is also supervisor as well as examiner of FCPS Part 2 endocrinology fellows. Dr. Ibrar Ahmed. The speaker of this session is Dr. Arshad Hussain. Dr. Arshad Hussain has been trained in Ireland. He is currently working as an associate professor of endocrinology at Northwest General Hospital, Peshawar. The topic of his talk is Incretin Mimetics-Weekly GLP-1 receptor agonist and DPP-4 inhibitors. Dr. Arshad Hussain, over to you.
Okay, Assalamu alaikum. Thank you very much to all of you for joining me. Let me just screen share. Okay, sorry, I just switched off the video only for the reason that the internet connection, is giving me a little trouble. So I hope it runs smoothly once I switch off the video. So I hope you can all hear me.
Yes, go ahead,
Okay.
Dr. Arshad.
Okay, thank you very much. Okay, so I'll just start my presentation with this slide, which you may have seen so many times, that type 2 diabetes is a progressive disease. And, with increasing hyperglycemia, there is a progressive loss of beta cell function accompanied by micro and macrovascular complication. And I don't need to really go through all of it but if you can see this, the microvascular and macrovascular complication. So I thought I'll just share that evidence has shown that impaired glucose tolerance, which you can see from this, is not associated with microvascular disease. And in fact, it is the incidence of retinopathy and nephropathy mostly correlate with severity of hyperglycemia and the duration of diabetes. In contrast, if you see the impaired glucose tolerance is associated with increased incidence of macrovascular disease. Now, you may have seen this slide, many times, the ominous optic. Just, it actually, slide shows the numerous factors implicated in the pathophysiology of type 2 diabetes, including those involving pancreas, liver, incretin system, brain, adipose tissue, muscle, and kidneys. And, just setting off the stage for my talk. So the principal mode of action of therapies to type 2 diabetes, you see in this picture, there's a metformin, there's a TZDs, sulfonylurea, glinides, alpha glucosidase inhibitors, SGLT2 inhibitors, DPP4 inhibitor, GLP-1 receptor agonist, and we all know their mechanism of action working on different parts of the body. And we'll be discussing GLP-1 today, and this was just an introduction. GLP-1 receptor agonists. So far, we know there are 7 cardiovascular outcome trials in the last 4 years. Used, they have used all these 7 different GLP-1 agonists, and all of them were multicenter, double-blind, randomized, and placebo. All have found non-inferiority for CVOT. Some have found superiority. This was the patient population, used in different GLP-1s. And as you can see, the highlighted part is actually the one who actually had a previous cardiovascular disease, which you can see clearly that, all of them who were included in this trial, they had cardiovascular disease from before. I think the interesting part is really the one in Alexa, which is, most of them had a previous cardiovascular disease. And then the Rewind trial was known for having, less number of patients having previous cardiovascular disease. We'll be discussing only 2 GLP-1, weekly GLP-1 agonists today. And those ones are the semaglutide and dulaglutide. Because dulaglutide is available in Pakistan and semaglutide is about to come. I know there are other weekly GLP-1s available, but they're not available in Pakistan, so we'll be discussing these 2. So as we know, GLP-1 Rs have multifactorial effects. The pharmacological effects of GLP-1 Rs, as you can see here, are on pancreas, beta cell, increase the beta cell function, insulin biosynthesis, and they work on the liver as well for reducing hepatic glucose production and lipotoxicity. It works on the brain as well. You can see in pancreas, it reduces the glucagon secretion apart from increasing, the insulin biosynthesis and the beta cell function. It works on the GI tract, reducing gastric emptying. It works on the kidneys as well. And it also works on the muscle, increasing insulin sensitivity. And this diagram just shows, some of the cardiovascular effects of GLP-1 receptor agonists, like anti-atherosclerotic effect, increase, in the endothelial function, the risk factors modification, like, improving glycemic control, reducing insulin resistance, reducing body weight, trigs, LDL, and also blood pressure. And it has been used, in different studies, and it has shown that it reduces the infarct injury size, and it has some other anti-inflammatory effects as well. Now, as we know that GLP-1 receptor agonists vary in molecular structure and size. On your left, you see the exendin-based GLP-1 receptor agonist, which is exenatide and lixisenatide. On the right, you see these 4. Which is the liraglutide, which is the human GLP-1 analogs. These 4 are all human GLP-1 analogs, but some of them have smaller and some of them have larger molecules. The smaller one are liraglutide and semaglutide, and the larger one is a dulaglutide and albiglutide. And just to note that albiglutide was withdrawn from the worldwide market in July 2018. And there is always, a question why they all perform differently, why they have different results. So if you look at this different pharmacokinetics for all of the GLP-1 receptor agonists at steady state, and that is the reason, that you may be seeing different results. So coming to the semaglutide, straight to the topic. So semaglutide is a close analog of native human GLP-1. It has 94% structural homology, and 3 important structural modifications have been made at position 8, 34, and 26. The amino acid substitution, position 8, makes it less susceptible to degradation by DPP-4 inhibitors. And as we know, semaglutide is suitable for once-weekly dosing. The steady-state concentration following last administration of 1 milligram semaglutide are shown on the graph. And there is initial rise in the concentration from around 12 hours post-dose and a plateau, and then profile exhibited a gradual decrease from around 72 hours post-dosing. And this is the PK profile of approved GLP-1 receptor agonist. So you can see here in the middle, the T half. And for exenatide is up to 2.4 hours, lixisenatide 3 hours. But if you come here and look at the dulaglutide, it's about 4 days, semaglutide about 7 days, and exenatide once weekly is also somewhere between 7 to 14 days. Then we come to the semaglutide increases the first and the second phase insulin. So this is actually from a study in which 3,635 randomized single center double blind trial subjects with type 2 diabetes to evaluate the effect of semaglutide in steady state on first and second phase insulin. The first phase insulin 0 to 2 minutes and second phase 10 to 120 minute, area under the curve for insulin were increased after 12 weeks of treatment with semaglutide versus placebo. That's the one which you see there. And the maximal insulin secretory capacity was increased after, they checked it later on whether really, after if you see here on the left here, on the top here, intravenous glucose tolerance test was done. And that was, the way to check the first and second phase insulin response. And not only that, but, from the same study that they actually analyzed, and, the same 3,635 randomized trial, and following semaglutide, it increased semaglutide treatment. You can see the glucagon level was significantly. Let me just play all this here. The glucagon levels you can see significantly decreased versus placebo. The serum insulin slope for semaglutide closely resembled that for a healthy adult, but was distinct from the slope from subject with type 2 diabetes receiving placebo. And beta cell responsiveness was increased after semaglutide treatment and was comparable with the healthy controls. Now, coming to this slide, the graded glucose infusion test, semaglutide increasing beta cell responsiveness to level comparable with healthy controls. So this was, they checked the 24-hour profile, the mean 24-hour profile for, this one. So we checked the semaglutide, we came to know the semaglutide increasing fasting C-peptide and decreased postprandial glucose and glucagon. So this was, the 24-hour profile was done. Mean 24-hour profile for C-peptide, plasma glucose, and plasma glucagon by treatment group are as shown. So the post hoc analysis demonstrated that compared with the placebo, C-peptide values were increased after semaglutide treatment, while fasting glucose and glucagon were significantly decreased. And the area under the curve 0 to 24 hours for glucose and glucagon was significantly reduced after semaglutide treatment compared with the placebo. So the fasting, we can say the fasting and postprandial glucose and glucagon were reduced in 24-hour profile by semaglutide. And as you can see, the summary of the semaglutide mechanism of action, it summarizes the key messages from the semaglutide mechanism of action, including non-clinical and clinical data on blood glucose levels, body weight, cardiovascular risk factors, And we know that semaglutide increases insulin secretion and beta cell responsiveness and suppresses hepatic glucose output in a glucose-dependent manner. And semaglutide reduces energy intake, food consumption, and body weight in subject versus placebo. And semaglutide attenuates atherosclerotic plaque progression in atherosclerotic mouse models, which you see here on the right. Now, change of HbA1c from baseline. So these were all sustained 1 to 5 and 7 to 10 studies. And the primary endpoint between all these studies was HbA1c, change in HbA1c from baseline to the end treatment. So in sustained 1 to 5 and 7 to 10, this was calculated, using estimated means. So semaglutide demonstrated significant and sustained reduction in HbA1c versus the comparators in all trials. As you can see from here, the magnitude of change of HbA1c from baseline was consistent with the semaglutide across all trials. And as you can see here, that not only the change in HbA1c was compared with sitagliptin and cana with oral antidiabetic drugs, it was also checked, and compared with the other GLP-1 receptor agonists like exenatide, dulaglutide, and liraglutide. And as you can see, the light blue color is the semaglutide 0.5, and the dark blue color is 1 milligram, which is the maximum dose. And you can see, quite significant change and drop in HbA1c. Okay, change in the body weight. What about the change in the body weight? So weight gain and obesity, as we know, are associated with an increased risk of CV complication, and excess weight is an important contributing factor in the complex etiology of type 2 diabetes. Semaglutide was associated with a significant reduction in weight versus comparator in all these trials. In case of semaglutide 1 milligram, the degree of weight loss was at least twice as great as the respective comparator in each trial. So again, the light blue color, as you say, semaglutide 0.5, and this one is the semaglutide 1 milligram. And as you can see, what I said that, in case of semaglutide 1 milligram, the weight loss was at least twice as great as the comparator. Now, proportion of subjects reporting GI adverse events. These are all gastrointestinal events such as nausea. They were the most common frequent side effects with the semaglutide. And there is a comparison, with the other GLP-1 receptor agonist. Okay, severe or background confirmed symptomatic hypoglycemia. We always, worry about hypoglycemia using any of the drug, for lowering the glucose level. And as you can see, semaglutide has a glucose. We know that semaglutide has a glucose-dependent mechanism of action, and the risk of hypoglycemia was anticipated to be lower with the treatment, than with the treatment like insulin and sulfonylurea. The rates of hypoglycemia, as you can see, were low unless treatment was combined with sulfonylurea or insulin. And they were somewhat higher in sustained 3 to 5 trial where the hypoglycemia was because of the sulfonylurea or the insulin. Now, the sustained 6 is one of the trial which is quoted most of the time, and I think that is the one we're going to discuss. These composite outcome of the sustained 6. So the sustained 6, the incidence of each component is assessed individually. So CV death, that occurred in fewer subjects treated with semaglutide than placebo. However, this was not statistically significant. Non-fatal MI occurred in fewer subjects treated with semaglutide than placebo, although this was not statistically significant. Non-fatal stroke occurred in significantly fewer subjects treatment semaglutide than placebo. It was slightly more significant than the previous one. The expanded outcome, composite outcome, was the first occurrence of CV death, non-fatal MI, non-fatal stroke, revascularization, unstable angina requiring hospitalization, or heart failure. And this occurred in significantly fewer subjects treated with semaglutide than placebo. Interesting one is the nephropathy Outcomes: new or worsening nephropathy, and new or worsening nephropathy was defined as persistent macroalbuminuria, persisting doubling of the serum creatinine level, or the need for continuous renal replacement therapy. And nephropathy associated with type 2 is the leading cause of CKD, as we all know. In Sustain 6, the risk of new or worsening nephropathy was significantly reduced with semaglutide compared with placebo. So in the semaglutide group, it was 3.8%, and in the placebo group is 6.1% developed worsening nephropathy. What about diabetes retinopathy complication? That was an interesting finding as well. Semaglutide was associated with a higher rate of DRC versus placebo in the Sustain 6 trial. And HbA1c reductions related to the diabetic retinopathy complication. In the overall trial population, semaglutide treated subject experienced significant and sustained reductions in HbA1c from baseline versus placebo. And the reduction in HbA1c was greater with semaglutide and placebo in subject experiencing this diabetic retinopathy complication versus the overall population. And just to note that at week 16, the decrease in HbA1c was 1.6% and 2.5%. 1.9, sorry, and 2.5, apologies. 1.9% for 0.5 milligrams semaglutide and 2.5% decrease in HbA1c for 1 milligram of semaglutide, during the trial period. And not only that, semaglutide improves postprandial lipid profile. And it's again the same study, 3,600 patients, and it again, compared, the study comprised of 12 weeks crossover treatment separated by washout period. But as you can see, there was an improvement in trigs, VLDL, fatty acids, and apolipoprotein. So what about the long-term outcome of Sustain 6? As you can see, quite significantly, if you look on your left, you start from the left, the primary outcome of CV death, non-fatal MI, non-fatal stroke, reduced by 26% risk reduction versus placebo. Number needed to treat to prevent one CV death, non-fatal MI or non-fatal stroke is 45 for 2 years. And we also know semaglutide reduced the HbA1c and body weight versus placebo. And risk of new or worsening nephropathy, there was 36% risk reduction versus placebo. The risk of diabetic retinopathy complication was increased by 76% versus placebo. So that ends the semaglutide. Now we're coming to the dulaglutide. Semaglutide is about to be introduced in Pakistan, and hopefully soon in the near future. Dulaglutide is available, I think, for the last few years' time. So this is the second part of the talk we are going to cover. So Trulicity is the trade name, generic of dulaglutide. It's a once-weekly GLP-1 agonist, and there are 2 GLP molecules attached to modified IgG4 Fc domain way linker. Extended plasma half-life of 5 days, low immunogenicity, minimal renal clearance, and no reconstitution needed. And this is the natural history of type 2 diabetes and the Trulicity in the award program. The award program, they compared Trulicity as a monotherapy or with other drug combination. So as you can see, is the beta cell function, with the time, the longer you have the diabetes, the worse the beta cell function. So they started adding on more and more medication and compared this, in monotherapy, 2 drug combination, 3 drug combination, and more complex insulin strategies. And, there are more than 6,700 patients recruited on these trials. This is the dulaglutide phase 3 clinical trial results. It has been compared with exenatide, also with insulin glargine, with metformin, insulin glargine, sitagliptin, and liraglutide, again glargine in CKD patient, and sulfonylurea, and glargine and dula combination, and also SGLT2 and dulaglutide. And Trulicity provided HbA1c reduction with once weekly dosing, and this is the orange color is the Trulicity, and the other one is usually the active comparator. So this is against acetagliptin, this is against add-on to metformin compared to liraglutide. So this is liraglutide, and this is a Trulicity, and this is comparing with exenatide adding on to metformin, and this is also glargine. So the main point really is once weekly Trulicity deliver proven glycemic control in clinical trial with a range of HbA1c reduction from baseline of 1.08 to 1.51% for the 1.5 milligram dosage. And not only that, Trulicity provided HbA1c reduction with once weekly dosing in a head-to-head clinical trial. And this insulin glargine you can see versus Trulicity. And Trulicity lowered fasting glucose by week 2, and Trulicity decreased glucose after 2 weeks of treatment. This decrease was sustained up to 52 weeks, as you can see there in the chart. And not only that, Trulicity has a greater decrease in overall postprandial glucose versus insulin. And what you see here is the 8-point self-monitor plasma glucose profile between Trulicity and insulin glargine. And Trulicity has a greater decrease in postprandial glucose. And at 52 weeks, if you see the fasting plasma glucose from 8-point SMPG profile decrease more with insulin glargine than with Trulicity. The decrease in baseline for the 2-hour postprandial was similar after the morning and midday meals and greater after the evening meal with Trulicity, resulting in greater decrease from baseline to overall daily mean of postprandial glucose. Trulicity once weekly GLP-1 has achieved non-inferiority in once daily liraglutide in HbA1c reduction. However, the point to note is this is at the cost of 85% fewer injections with Trulicity than with the liraglutide. Quite impressive. And Trulicity 1.5 milligram treated patients experience weight loss regardless of the concomitant therapy. It was compared with so many drugs, but despite of that, whichever group it was, it still showed that there was significant weight loss. As you can see here, against metformin, this is Trulicity, and acetagliptin, metformin, and pioglitazone obviously, and glimepiride. Glimepiride caused some weight gain, and this caused weight loss, which is quite understandable. And okay, so the weight loss regardless of concomitant therapy, we just want to highlight the two things here. Here is the liraglutide and Trulicity, and here is a Trulicity and insulin glargine. Of course, I think with the basal insulin, I think it was expected there would be some weight gain, but Trulicity caused significant weight loss. Comparable incidence of hypoglycemia, that's also another thing. So really this table shows the incidence of total hypoglycemia events per patient year and severe hypoglycemia in head-to-head study with liraglutide. The hypoglycemia, as you can see, occurred more frequently with Trulicity, but that was when it was used with the sulfonylurea or insulin. And severe hypoglycemia occurred in 0.7% of patients when Trulicity was co-administered with sulfonylurea. That's the breakdown of it. And severe hypoglycemia occurred in 3.4% of patients when Trulicity was co-administered with prandial insulin. So prandial insulin and sulfonylurea both increase the risk of having a hypoglycemia. And the weight reduction, as we have already discussed at week 26, you can see there is quite significant weight reduction. However, a thing to notice, the label says that Trulicity is not indicated for weight loss. Weight change was a secondary endpoint in the clinical trial. And this is just, nausea typically occurred upon treatment, but it lasted for up to 2 weeks' time and then subsided. What about the pancreatic safety? Whenever there's a talk about GLP-1, I think there is always a talk about pancreatic safety. So the GLP-1, we know it has been associated with developing acute pancreatitis, and the incidence of acute pancreatitis in trials shown for Trulicity is 0.7% for Trulicity, 0.14% for placebo, and 0.19% for the comparators, with or without additional background of antidiabetic medication. And I thought there should be a mention of Rewind study. The Rewind study was, not so recently, but recently, you can say in the recent past, it was, done, and it was a cardiovascular outcome trial tested for superiority. They were again looking for primary outcome was, non-fatal MI, stroke, or death from CV cause. About 9,000 patients, at age 50 were followed for 5.4 years. Only 31% had a previous CVD. Primary outcome, composite outcome occurred in 12 versus 13.4 in placebo. There were few renal outcomes, and eye outcome was also 1.9 versus 1.5% in placebo. And this study was unique in that it was the longest trial with low-risk population. Most participants had no previous CVD, yet still showed a reduction in composite CV outcome. This leaves us with a question whether GLP-1 could they have a role in primary prevention of CVD? So the summary so far, once-weekly GLP-1 agonists for good HbA1c reduction and weight loss. They are safer, benefit of once-weekly injection, 85% less injection versus daily GLP-1 receptor agonists. They are cardiovascular safe, and there is a very few slides about the DPP-4 inhibitor. These are the 13 different inhibitors available, DPP-4 inhibitors available, and as you know, this is from the examined study that similar, DPP-4 had similar primary outcome, but they had different secondary outcomes, and we'll be talking about the once weekly. So once weekly, there are two DPP-4 inhibitors available, and one is a trilagliptin. It was, the weekly it is the weekly DPP-4 inhibitor, and there was a study, a 24-week study, which showed monotherapy as a monotherapy. It showed HbA1c reduction of 0.33%, improvement in fasting and 2-hour plasma glucose. It was weight neutral. There was no weight gain or weight loss with it. No effect on frequency of hypoglycemia events. And phase 3 trial for 52 weeks in combination with other drugs was well tolerated with a significant HbA1c reduction. Also, there is a data which indicates it's highly selective and potent DPP-4 inhibitor, about 4 and 12-fold more potent than allogliptin and sitagliptin respectively. And significant HbA1c reduction, which was maintained until 52 weeks, in a phase 3 trial. And the dose is usually 100 milligram in adults once weekly by mouth. A patient with moderate kidney disease, given the drug concentration will elevate due to delayed elimination. So the dosage, there is a recommendation, the dose should be reduced to half. And the creatinine clearance of 30 to 50, that there is a recommendation for dose reduction to 50 milligrams. And the dissociation half-life of trilagliptin is approximately 30 minutes, and it's eliminated through urine in humans. And trilagliptin is going to be available in Pakistan soon, so that is also coming. That's why it was part of the talk. Omarigliptin was also, on the list, but it isn't available anymore. It is a small molecule developed by Merck for oral treatment of type 2 diabetes once weekly at 12.5 and 25 milligram. There was a meta-analysis. There were 11 trials done on this drug, about 8,000 patients. And it was a very good drug, significant HbA1c reduction, also glucose control, and it was otherwise safer. However, it was withdrawn as they were concerned about high rates of prostate cancer in some of the patients, but the main reason was really hepatobiliary issues. But interestingly, the company is switched, and I think it's looking into a different use. It's currently being studied for its use intranasally in Parkinson's disease, and that research is going on. And I leave you with this slide that the two questions, research questions, at the end, that do GLP-1 have a role in primary prevention of CVD for patients type 2 diabetes? And question number 2, do GLP-1 have a role in CVD protection in patients without type 2 diabetes? And thank you very much for your attention.
Thank you very much, Dr. Arshad, for your very illustrative and precise talk and new data regarding regarding this weekly DPP4 inhibitors as well as semaglutide. There is no question in chat box till now. I would like to request Dr. Ibrar for his comments.
Thank you, Dr. Sarwar, for your kind introduction. And thank you, Dr. Arshad. Arshad had given a very detailed talk regarding weekly GLP-1 and DPP4s. Regarding diabetes care, we all were optimistic that we should be on some therapy which act on different sides. With DPP4, with GLP-1, we all were very happy with it. But with passage of time, with cardiovascular outcome trials results, GLP had an edge over DPP4 in different trials as discussed by Dr. Arshad. Regarding GLP-1, we were very much, when weekly was launched, we were very pessimistic regarding this side effect profile. We think that there may be some side effects which will prolong a full week. But as we had an experience regarding we get good results in HbA1c reduction, and patients had a very in side effects profile, they had very good adherence. Regarding adherence, regarding to the therapy, with weekly GLP-1, we could have a good results, and we had a clinical, also we had a clinical experience. Patients who had a weekly, we put on weekly GLP-1, their HbA1c profile, their weight reduction was much better, was as compared on and much better as compared to weekly GLP-1s. So, but the only thing was this cost issue. I was just reading out the previous literatures that the cost issue is not in our setups. It is also there in outside in developed countries, because where there's an insurance, there's no insurance, they struggle with this costly drug. So I think Dr. Arshad had covered it very well, and we are looking forward for it. Thank you from my side.
I think Professor H. Aamir would like to ask a question from Dr. Arshad Hussain. Professor H. Aamir.
Yeah, thank you, Arshad, and thank you, Sarwar, for the opportunity. It's not a question, it's a comment. I think I would say more of a comment. And I think without any doubt, it looks as if, GLP are the way to go with the days to come. But I think, as Ibrar has just mentioned, I think with the passage of time, it will be efficacy, yes, but I think it will also involve what the adherence level of a person is in terms of diabetes. You and I know that we know what is best for the patient, but whether the patient knows and whether the patient can adhere because of side effects, because of the technique for that matter, because sema versus dula, there's a big difference between the, use and how frequently it has to be used and the way it has to be used. So I think, I really think that with the passage of time, the science will remain the science. There's no doubt about that. And it will only improve our confidence. But what is important from the patient perspective will be how much they can comply with the diet and treatment, and how much they can adhere to the treatment. I think this is what needs to be seen, and we have seen time and again that this is what matters at the end. And I would need your comment on that, Arshad.
Thank you, Professor H. Aamir, for your comments. Dr. Omar wants to question from Dr. Arshad. Dr. Omar Yusuf.
Arshad, again, a wonderful presentation. Now, the theme of our session was actually from daily to weekly perspective or weekly treatments. And I think it will be quite interesting future for all of us who are working the care of or the field of diabetes, that slowly we are going from daily insulins to weekly insulins, and from daily GLP-1 agonists to weekly GLP-1 agonists, and from daily DPP-4 inhibitors to weekly DPP-4 inhibitors. But the other interesting thing is about we are already combining daily GLP-1 agonist with daily insulins. What about combining weekly GLP-1 agonists with weekly insulins? Any thoughts about those?
Well, Omar, as Dr. Amir has mentioned, I know diabetes is a disease of discipline. They say you have to be disciplined to take your meals regularly, do the walk regularly, take your medication regularly. Coming to weekly, yes, of course, we're looking for an easy time for the patient. They may be on too many injections, they may be taking too many pills, and once a week would be something which might suit them. It will improve the compliance. And if you remember one of the slide, I showed you that, the same HbA1c reduction, which you can do with the daily liraglutide injection, you can get it with once weekly injection of dulaglutide. So, if the results are very good, then why not? That is a very good choice as well. And I think if you're moving towards, much easier life for the patient, your suggestion or your thinking, I think I was thinking the same as well. I thought I'd leave the third question as, how would it look if we have once weekly insulin and once weekly GLP-1 analog and you're done for the whole week? But again, the question comes, as Dr. Aamir has mentioned, I think the patient has to be more disciplined. They have to take some responsibility for the care of their own diabetes and not only the medication. So that will be just one downside of it, that everybody will take it easy and say, okay, fine. Like, at the same time, we ask them to go for a walk every day, do some light exercises, and do look after your diet every day. But at the same time, we're giving them injections, which is only once a week, and they forget about taking any other medication for the whole week. But anyway, that's just my view on it.
Here is another question. Which one is best GLP-1 agonist regarding Victoza and Trulicity? One of the participants is asking. Dr. Arshad, would you say something?
Well, both are very good, in their own, domains, and depends really what the needs of the patient are. Not every drug is for everyone, so every drug has to be tapered down to, the patient's needs. Liraglutide is available since long, and dulaglutide has come only since for the last 4 or 5 years. So people may have more experience with liraglutide and they may be using it more. But then, if you look at from other perspective, any injection which you take every day, psychologically you inject yourself and you think, why I'm injecting this injection? I'm injecting it only to control my diabetes and maybe my appetite as well. So it makes you think, that yes, I have to do something about my diabetes. So that is also one point. Second, liraglutide mostly used in those people who, whose appetite is ferocious. They eat a lot as well. And if you think you give the daily dose of high dose liraglutide, it makes them nauseous, at least make them having a full stomach, so they may eat a lot less. However, having said that, even dulaglutide, if you take it once a week, it can cause this nauseated feeling or fullness of the stomach for the first few days, and that remains for the rest of the week maybe as well. So I think both are equal, and it depends really what your patient needs are. Say if you have a patient who doesn't want to go on injectable therapy but agrees to once weekly injection, then dulaglutide is probably the way to go. Hello?
Yes, Sarwar.
Hello? Sarwar?
I think there's some connection problem from Dr. Sarwar. So, Arshad, there's another question from the panelists, if I can just go ahead with that. And Shahryar and Sari have asked about Trulicity reduced weight, so it is obvious to be prescribed to obese type 2 diabetic. What if it is given to non-obese patient? Will it also reduce the weight further, or it will be weight neutral for that particular patient?
You mean for the non-diabetic?
So no,
for the
they are
diabetic,
diabetic, but their BMI say about 25, 26, type 2 diabetes. Do you think that there will be a weight reduction with these patients as well? And how much weight they will lose, if any?
Well, I think as I mentioned in the slide, in the label, the dulaglutide says that, it's not a weight reduction they're not promoting it as a drug for weight reduction. However, that's a secondary endpoint they've used in the studies. It has weight loss effect as well and sugar control as well. So those who are more obese, there is a tendency that you will lose, if you if you're compliant, you might lose a little bit more weight as compared to those who are less obese. So someone who is very less obese, of course, they might lose some weight, but the weight loss is going to be minimal. And for those who are very, very obese, I don't know whether, maybe you should consider other options like bariatric surgeries or all those, rather than GLP-1.
And if I can come, Arshad, on that, because there's an ABCD data, and ABCD data, again from UK, have clearly shown that the greater the weight is, the greater you are going to lose, or you are going to see the weight loss. So
yes.
Certainly, I think for the lean patient, we have got other options, much better options to use instead of GLP-1 agonists, which is much expensive. But if you start them on GLP-1 agonists, even if they're not obese, for say diabetes purposes, you might expect weight loss, but maybe not as much as you expect with some of the BMIs, say over 30 or 35.
That's true.
I'd like to
as you said, for
interfere.
example, someone with multiple daily dose injections, you want to cut down their dosage as well, and at the same time get a better control. And as you said, you start them on GLP-1, they're not very obese, so they might lose a little bit of weight, but not that much. That's true.
Arshad, as we are in time, it's the time for the last question. I would like to ask Dr. Tejhmal Rehman to ask the last question. Thank you, Dr. Tejhmal Rehman. Over to you.
Thank you. I think it's just an extension of Dr. Omar's question to use GLP-1 in relatively lean people. I think BMI 25, 26, obviously, firstly, that is still our weight for Asian population. And secondly, my question to Dr. Arshad is, if we use GLP-1 in people with a BMI of 22, 23, does it have any preferential benefit to lose visceral fat and improve inflammation? Is there any, are there any data on that?
I don't have really any data on that. I know, as what you mentioned, theoretically or hypothetically, yes, there is, but I think as such, there is no data. I don't know as far as I know. Maybe Omar might have some comment on it, but I don't.
Thank you, Arshad.
And even I haven't knew about any such data myself.
And sorry to cut you all, guys. Thank you. I would like to wrap it up as promised. It has to be wrapped up at 10. We are right on time. I would like to thank again our extended and our respected panel of experts, Professor Aamir for always being there, and Dr. Ibrar Ahmed for just letting him available for this session. I would like to thank Tejhmal and Professor Jones for being there and for enlightening us with their useful talk. And lastly, and not least, lastly, the Professor Dr. Arshad Hussain, my brother, my elder brother, and my colleague for a wonderful talk. And I would like you to all, we will inshallah be meeting in particular in person everywhere. And last talks from Dr. Umar Yusuf before we wrap it up. So kindly get a thanks for every speaker.
So I think I would like to end by thanking especially Professor David Russell Jones, and thanks to Tejhmal for all your help. And again, as usual, Arshad being brilliant in his talk, and Professor Aamir, Ibrar, and the sport team as well. It's dot on 3:30 p.m. So goodbye, everyone, and good luck in the future. And I hope Prof will come face to face, hopefully in our next annual meeting. We will
Midsummer, inshallah.
Thank you very much.
Thank you, everybody.
Bye-bye.
Cheers. Cheers. Bye-bye. Cheers.